So that's the, you know, I'm always surprised I get invited back to San Diego because I don't drink coffee, so I never go to Starbucks. I did all my work on an Apple laptop, and I flew here on an Airbus, and I don't have an Amazon account. And the other thing that I never do is never follow Neil, which is unfortunate that I have to follow Neil now. But I do like to follow a couple people. I heard 2 or 3 things today that I wanted to talk about is number 1, someone mentioned like chance of bowel injury with prone, which we're gonna dispel. Number 2, 4-5 access, which we're gonna dispel. And then difficulties with thoracolumbar junction, which I also hope to dispel, all in 15 minutes. So we're gonna go through each slide very, very quickly. But I would tell you the first thing I would say is, you're gonna see, I absolutely agree with Neil, is that you have to become more sophisticated about your approach to the spine when you're doing it, especially when you're going through the transpsoas. The idea that you can just arbitrarily go through any spot, and you'll see from our pictures, 4-5 and 3-4, almost everybody now rotates the bed so you get it oblique. And you do a little bit of an oblique approach, 2-bladed retractor then allows you to open up exactly like you do, rather than trying to open up the whole thing. So I think we've become much more sophisticated as we go along, and I hope to be able to impart a little of that. And I do agree, the biggest problem is 5-1, right? I mean, the lateral approach, when you're there, you can do 5-1 LLIF. And I think we've kind of worked on a few things. We'll show one picture at the end where we might make a little headway in that. So this is, wow. Where are we? Started here. Oh, sorry. There you go. Oh, there we go. Okay, this is me. That's Louise up in the top. We wouldn't be talking about lateral without Louise. Get most of ideas after drinking a little wine. This is what I always feel like in the bottom right when I'm talking. You know, you've got someone holding up a picture. No one has any idea what they're saying, but it's really important to them. And this is really the first paper from a long time ago that we published. That's my disclosures, which I haven't seen anyone else, but those are where I'd prefer to be if you want to know the truth. And the real thing I'm here to disclose is I am not here to take away your lateral. It's not my goal to tell you you can't do lateral surgery, either it's bad or anything else, especially if you're looking at doing 5-1. I still do lateral surgery, but I think what you're going to see is we got a lot of things that really make a difference when you put someone prone, especially for the right patients. Someone called me yesterday and they had a adjacent level disease at 2-3. The spine was completely ankylosed. It was solidly fused, and they called me up complaining because they'd put an expandable cage in and they hadn't gotten 20 degrees of correction at 2-3 with an ankylosed spine. I mean, again, you have to take into account exactly what patient you're dealing with. So what do? The idea is promote lordosis, maintain correction, prevent subsidence, large grafts, reduce complications. I will tell you exactly the same, 18 size graft. When you have a 2-bladed retractor, you only need to open that retractor 18 millimeters, and you can put in a 22 cage. So you get the advantage of a large cage if you want to, and the smaller opening, which decreases your injury to the psoas muscles, and also decreases dissection across the disc spaces where you get the iliopsoas nerves too. Those are ventral roots to the iliopsoas. Access to 4-5 is improved when you're prone. 5-1, still a problem, but I think we'll show something that might help. And the streamline speeds up surgery. Utilizing navigation is critical for me. I do every case now with navigation. It's much harder to do navigation in the lateral position. I also think it simplifies your decision-making when you're talking about it. You no longer get hung up in indirect decompression, posterior instrumentation, lateral plates, laminectomy, posterior fusion. You don't get hung up in all that. You can make that decision exactly what you would normally do, and you take advantage of the interbody implant with what it does best, which is promote fusion, distraction, prevent subsidence. Those things are great with an interbody implant laterally, and that's what it does best. And we can really do complex cases. So all of those things help us out when we get there. So why did I go from lateral to prone? And again, I'm not here to take away your lateral surgery, but I would tell you it does require a flip, right? I no longer have to flip my patients. I work in an academic setting, so for me, it was actually an advantage because I would go and answer my emails and see a few patients while the residents were flipping the case, but that's not always the case with everybody. Limited reduction, so we'll all show a few cases where you can reduce either by positioning or by instrumentation, which is really nice to be able to do. And lordosis is definitely improved, which we can look at. Forgetting indirect decompression, if you're not interested in it, is a nice thing to do. And then I found it really hard to do more complex procedures from the posterior column. And also, we've reduced the neural complications by turning the patient prone. So we're going to go quickly through this. This is really just the start of it, and to remind people why it's important to use certain instrumentation. Old 3-bladed retractor, put it in the lateral position, very heavy, unwieldy. If you don't have a frame, the retractor falls away from the patient all the time, and then that's us struggling with a big retractor, holding onto the patient if they don't move, getting the fluoro out because we've abandoned the navigation piece. The arm, you can see, is in our way when we're trying to work, and all of these things over the last 5 years have sort of been fixed quite a bit. I would say this top picture on the right is the most important. That K-wire is our initial dilator. You see where that initial K-wire is, right? It's in the front of the disc space, okay? So I position my patient depending on what level I'm working at. I rotate the bed at 4-5. I might go to the middle if I'm oblique. If I leave the patient directly lateral, I can target the anterior portion of the disc space. With a 2-bladed retractor, you can put your first dilator and your first K-wire in any location you want and then open the retractor in the opposite direction. So the 2-bladed retractor has become really important. The second thing the 2-bladed retractor does, you only have to open the retractor as much as the implant you're putting in. So if you're putting an 18-millimeter implant, you only need to open it about 15 millimeters. If you're putting a 22 implant, you only need to open it about 22. All of those things have helped decrease some of the problems that people have had with the lateral approach, and I think are really important. And honestly, goes along exactly with what you talked about with what's important with doing the oblique. And I think what we've done now, my hope is that we split the difference. We've left you prone so you can work posteriorly, and then we've made it better by going in the lateral position and trying to avoid all the problems by directly lateral and docking very, very far posteriorly and pretending we weren't causing any problems. So, surgical decision-making, pre-op setup, much easier. Simultaneous access, both back and side. Spondylolisthesis reduction in the positioning and with instrumentation. Expanded posterior options depending on what you're doing, and then really simplifying your decision-making. I spent hours and hours lecturing on indirect decompression. We talked about it earlier today with LLIFs and looking at foraminal and clearing out the foramen and making the foramen larger and making the central canal bigger. But the fact is, we don't really know exactly how much we need to make it bigger. We don't actually know how much immobilization helps with that, and we don't really know all that matters. So the reality is I really like to do a direct decompression if I think I need to. And now when the patient's prone, I can very, very easily do that. So simple positioning. The frame is really important. Why is it important? It's important because it anchors the patient to the bed. It holds the frame and the retractor to the bed, and then you anchor the retractor to the frame. And so it doesn't move. You promote lordosis. This is the initial frame. You can get coronal bending from it. And the next of these is going to give you rotational correction. And also, we've noticed if you elevate 5-1 straight up, like the old frames used to do, you increase your lordosis at 5-1 if you're doing something posteriorly. So the frame now does a few things, but as you work, it's going to do more and more and more for you in that position. Simultaneous access, even if it's just someone closing the skin incision on the side while you're doing something in the back, I think is critical. Being able to work simultaneously. That's a great picture on the left. The reality is quite often you have the fluoro in there and it's difficult to do. It's not staged, but you really got to work at it to get both people on the other side. But it's as simple as removing instrumentation posteriorly, doing percutaneous pedicle screws, whatever it is you want to do posteriorly, you can do while someone's doing the lateral surgery. So the person's prone. The way that it works, especially for me, because I use navigation on every single case, is screws going first, okay? It wasn't always that way before. Lots of times you used to do the lateral. But screws going first allow you to reduce a spondy, all right? Which is really nice to be able to do, and then do the lateral. So reduce a spondy by screws or reduce a spondy just by positioning. So what happens when you go prone, too? A few things happen to the patient and happen to that person. Number one, psoas changes a little bit. The psoas moves posteriorly. It moves out of the path of your approach because you're posteriorly. If you look at the lateral pictures, when we first started, we told everyone, oh, you got to bend the knees to relax the psoas. And that was probably the absolute worst thing you could possibly do because it drags the psoas into the way of your approach. So the best thing you can do is leave the legs in neutral position. The psoas moves posteriorly, and we'll show some pictures on that. Plexus moves with the psoas, all right? That's clear that we've done. The perineum falls away. Bigger retroperitoneal space, easier access, especially if you're going a little bit oblique, and you gain lordosis, okay? You can't talk spine surgery anymore without at least saying lordosis 10 times, okay? It's the magic word, but we're promoting lordosis. And the iliac crest moves out of the way, and we can fix our spondies and reduce them. So patient positioning on psoas morphology, I don't know what happened there. We lost our, oh, there we are. So basically what happens when you turn the patient prone on the frame, okay? You can't turn the patient prone on the table without the frame and without suspending their abdomen. And you have to leave the legs in neutral position. You flex the legs, you flex the hips, the psoas starts to come forward. You position the patient prone, and there have been a couple studies where people said, oh, it doesn't really work. That's because they put the patient in the MRI scanner just prone on the table. The abdomen compresses out, the psoas muscles don't move. But with a little bit of extension and neutral legs, positioning prone in the frame moves the psoas posteriorly, and with it the lumbar plexus, giving you more access and less chance of going through the psoas muscle directly while you're doing the surgery. So, and this is a study done at Hospital for Special Surgery, basically saying, hey, okay, the psoas muscle moves a little posteriorly, but does that really drag the nerves with it? And the answer is yes. The femoral plexus, that's femoral nerve, lumbar plexus, moves posteriorly with the psoas muscle when you position the patient prone in a frame and you leave the legs in either neutral or slightly extended position. So the nerve goes with the psoas muscle as you move that, which gives you much, much more space to work in. And so that's really nice when someone does it prone. So we already had someone mention about bowel injuries with that. The reality is when you turn someone prone, you also increase the distance from the quadratus to the peritoneum in the retroperitoneal space. Now, the nice thing about that, too, is that we've kind of changed the approach. So you'll see when we do this, we're not going in directly lateral, but we're going and finding the quadratus and pushing everything down, okay? That allows the retractor not to fall forward. It makes it much easier for the approach, makes people much more comfortable rather than trying to drive straight into that area. So more retroperitoneal space, abdominal contents fall out of the way when you do it. The real important thing about lordosis, and this is a nice study that we did looking at. These are mostly 10-degree cages, some 15-degree cages thrown in, and also some 0-degree cages. So it's not well controlled. But what we found really is segmental lordosis is about 10 degrees. So what we really found is that when you position the patient prone, you gain about 5 degrees, okay? If you remember the studies from before, a lateral cage, lateral surgery gets you about 4 or 5 degrees for a 10-degree cage. So you get about 40 or 50%. So really what you're doing, you're getting the same amount with a lateral cage that you got with the person in the lateral position, but you're gaining 4 or 5 degrees at each level because you're turning the patient prone. Now what that means is you're not going to get 20 degrees from a 20-degree cage, okay? But 10 or 15 degrees, which is most common, is what you're going to get when you put that cage in. So a 15-degree cage gives you about 12 or 13 degrees, okay? 10-degree cage, about 10 degrees. And that's a really nice thing to be able to plan for to gain that extra lordosis. The other thing is the idea of hyperlordotic cages has really gone much, much, much less. I think those lead to subsidence. They lead to difficulties with positioning the cage and falling out, rupturing the ALL. And so pretty much if you need more correction and the person's prone, then what you should do is a release in the back and compress and get some harmonic correction that way. And that's really what we found happen with most people when they're prone. And that's really, really what we're looking at. So a little bit with positioning. This is a slide I borrowed from someone. I've actually never had that happen to me. I've never gotten that lucky when I position someone and everything works out to be in the same spot. So supposedly it happens sometime. I don't know if it's happened to anyone here, but I always put that slide in on purpose. So someone talked about 4-5. So what happens at 4-5? When you're at 4-5, if you look at the study we did in cadavers, in here, well, I don't know what that was. When you look at this is prone, no frame, legs in neutral position. So if you're just turning the patient prone and you've tried to do that case without a positioner or without a frame or without some lordotic, without suspending the abdomen, you put yourself in the least advantageous position. So the least access you have to 4-5 is when you just turn the patient prone on the table. If you do it laterally, this is lateral decubitus, that's mid-range, right? So laterally, you do actually gain some. But if you put the patient prone, you leave the legs in neutral position, you have the best possible access to 4-5 with a little bit of coronal bend. And that original picture I showed, what we normally did, we try to really extend those patients. You don't gain anything, and in fact, you make it worse with what's called an extended coronal bend. So mild coronal bend, straight or extended legs in a frame with the abdomen suspended is the most advantageous. Don't turn the patient prone, put them on a table. You put yourself in the worst possible position. And if you don't have that, stay with a lateral position, especially when you get to 4-5 with just a mild coronal bend. So access, correcting, especially for deformity cases, really nice. So what changes in prone? We had a comment, I actually added these while we were sitting over here. Someone talked about bowel injuries. The reality is when you go through that area, something is going to be a problem. And it may be with an LLIF. There's certainly numbers of bowel injuries and vascular injuries. This was the study that Juan did with as many patients as they could find with about 0.08%. The biggest study that we have to date of bowel injuries does not show an increased number of bowel injuries. This was about 500 cases we had, follow-up, 2-year follow-up, and good numbers and good data for this. And what we found was really no bowel injuries in this case. Left-sided approach almost all the time, single vein injury, and hospital stay of 2.2. So I really stress the fact that this idea that there's an increased risk of bowel injury is not really the case, especially if you find the quadratus, open up the retroperitoneal space as a start rather than diving straight in and then putting the patient in the frame. And these are really just the other, just general complications that we had. But what we really want to look at when you're prone is what are not just transient, because these things get better, but what is persistent femoral nerve palsy, injury to the lumbar plexus when the patient's prone, which mostly occur at 4-5. And the fact is, if you look at the other studies, you're up someplace around 2 or 3%, as high as 4 or 5%. In this case, 500 patients, 2 femoral nerve palsies, 0.5%. One of those femoral nerve palsies happened when the person ignored the saphenous SSEP monitoring for some reason and didn't follow along. So there really would have been 1 femoral nerve palsy out of that case. And again, that's not something that you want to see, but I think that's a pretty reasonable number. How do we do SSEPs? Remember, there's only one sensory branch of the femoral nerve, that's the saphenous nerve. So SSEPs, stimulating distal to proximal. You follow along, stimulate the saphenous nerve, you get real-time information of the femoral nerve specifically, and probably the lumbar plexus because it gets distracted with the other nerves. I would also make a comment about time too. So there's some idea that time is the critical factor, but it's also time and compression. These are ischemic injuries for the most part. You're passing a dilator, safe space with an EMG, and then you're compressing that nerve. So it's time, it's also pressure and ischemia. And the reality is saphenous SSEPs give you real-time information on the health of the femoral nerve and the lumbar plexus when you use them properly. And the saphenous SSEP monitoring, I took out the trade name, but there's only one company that has a automated SSEP monitoring. You absolutely can use your neurophysiologist to do it. They're not great at it, I can tell you why. Number one, saphenous SSEPs and SSEPs in general are very, very small signals. They're very small signals and they have to average them over time. So they average them for 5 or 10 minutes, they give you a report, so you get information 5 or 10 minutes down the road. The reality is, for this, when you're using saphenous SSEPs, this is in a group of about 75 patients, of some presumed positives, but the real thing to remember is, if you don't have a change in the SSEPs, you don't have an injury to the nerve. And so you're protected against doing that, so time becomes less of a factor. Now, I wouldn't recommend you spend 2 or 3 hours doing something, but the reality is the time piece was always just sort of an arbitrary number, which basically that's where the curve fit. It doesn't have anything physiologic that happens. So SSEPs are great. You can get false positive and false negatives, but in general, if it returns back to normal or you have no issue, then you're perfectly fine completing the surgery. The last thing that I really want to talk about too before we look at a few cases is navigation. I do really every case with navigation now. I will tell you, I keep the fluoro in the room, right? If you think the navigation's off or there's a problem or you want to check, you don't want to do another spin, it's not a failure to get the fluoro out and use it. But I use navigation for screws, I use navigation for the lateral in every single case. I do use the robot occasionally. I haven't really found the robot, nor have I got good enough to really use the robot to place that first dilator. It's too long of a reach. It's really difficult to get it in the right spot. I'm working on it, and you really would have to make a second fascial incision to pass your finger in and pass the dilator. But the idea being is you could target the disc space and where you wanted to go very, very safely. But I use the robot in every case now, and that's really nice when the patient's prone. PSIS pin, a spinous process array, whatever it is that you want to use. We have both the O-arm and the Aero CT. We use both of them in that spot. But there are roadblocks to that, and you have to be careful. So a couple cases. Number one, this is really just a nice deformity case in a relatively young person. I don't often use expandable cages. But in this case that I did, I think it's nice because I really like to be able to not hyperlordosis and over-distract. And if I want to do posterior facet release, I do it. I use the interbody cages both for correction, which works really well for distraction and for fusion. And we can also compress across there, which works really, really nicely in that spot. And so that's sort of what you get. Also, when you're doing some, we can go back to that one, sorry, I skipped over. So it's a nice correction at those levels. Also, we'll talk about what I do at 5.1 a little bit. This is clearly an LLIF at 5.1. So prone is also nice because it allows you simultaneous access for some of those more difficult cases. So collapsed case, collapsed instrumentation, failed instrumentation, access from the side, simultaneously with access from the back. Being able to do a corpectomy at that level in the prone position works really, really well. Everything falls away just like the abdomen, so we can put a large cage in there, distract, and also do posterior instrumentation at the same time. We've done a couple cases about spinal shortening. These are for people with recurrent tethered cords. And we picked T12 to do that because it's completely vertical. So you can see this is someone that has a tethered cord that's had 2 or 3 releases already. And that allows us posterior access, anterior access to do the corpectomy, and allows us to compress very easily. And this is just a picture of the posterior rods, T11 inferior end plate, looking at that, and from another way, looking at the disc space while we're looking at it from the lateral approach. So some people, then that's our result with a spinal shortening for tethered cord. It's a really nice. If you can do these cases prone at T12, then you're in good shape. I threw this in right at the end because someone recommended or said, boy, can you do a discectomy? And the reality is this was the last case that I did in a lateral position before a calcified thoracic disc. This is someone with both that needed a laminectomy and a discectomy at that level. And so this is T11-12 discectomy with a posterior laminectomy at the same time. Really, really nice to be able to do that. And certainly thoracolumbar junction, thoracic, and the calcified disc and thoracic discs, great access with prone positioning. The pleural falls down, the lung falls down out of the way, and it increases your space. This is really the last case. This is what I do mostly at 5-1 now. I put 2 cages in with a TLIF approach. We're publishing this. I wish I could tell you I got great lordosis from doing that. It's not as good as I'd like. When I look back at my numbers, I thought I had done a lot better. So I'm a little disappointed. I'm not sure quite what to do. But we have essentially prevented subsidence. So we prevented that subsidence from the TLIF because we covered the end plate just as much as we did with the lateral surgery. This is a TLIF at 2 levels now. You can see we have 2 cages in both sides. So I'll put 2 cages in when the patient's prone. The next really step, and I've done it a few times, is releasing the ALL, which I don't think we're going to do too often. Extandable cage maybe in the front and something behind. But I do think that there are options at 5-1 that prevent subsidence and promote lordosis, and I think some of that is going to be done with the frame in the future rather than having to do an ALIF in that spot. So what do you get from going prone? Simultaneous, LAMI, release, working simultaneously, even if it's just the closing, decompression, and you really get single position surgery without the difficulties of doing something in lateral approach. I was never really very good at laminectomies and pedicle screws and doing anything in the lateral. I really didn't like doing that, so I would always flip the patient back and forth. Psoas muscle moves posteriorly. Also, rotating the bed while the patient's prone is really easy, reduces any problems, neural complications less, and I think really what you get is really easier decision making. Direct and indirect decompression and other things really go out the window. And the last piece, which I think is really important, is continuing with navigation. So that's where we ended up doing the PTP from lateral. And anyone has any questions, let me know.
Bill, comprehensive talk, and seeing the evolution of the procedure is actually pretty interesting. And I can see you tackled every sort of perceived problem from a prone lateral. But I would say, like, people who aren't comfortable with lateral surgery and then going prone lateral, it's a big step. So all those things you've mentioned, I think, are still a bit of a barrier. And I think it comes down to like giving presentations like this and training, really.
Yeah, I think there's a little bit of a barrier too in doing that. But once you really start doing it, and my barrier was I didn't want to do thoracic cases. I didn't want to do anything else. And I was also worried about the amount of correction too. But I think we're past that now. You're going to ask a question? No? Good?
Bill, great talk as always. Is there any indication for you now to go lateral? Or?
Yeah, so the lateral surgery for me is really not much. The only time I'm going to do it, the next time I'm going to do it, is I have someone I'm working with a really high thoracic disc. And it's really hard to get your arm and everything out of the way when you're in the prone position. So you really got to move the scapula and get out of the way. So higher thoracic discs, I'll still do in the lateral position.
Hey, Bill, I just wanted to clarify one point. So in the studies looking at lordosis, if you do a lateral in the lateral position and then put the patient prone and put in perc screws versus doing it all prone, you're saying that there's a difference in lordosis in that scenario?
Yeah, so what I think happens, and I don't know this for sure because we're still looking at it, is that I do think once you put the cage in, then those cages are really big, and I don't know what Neil thinks, but I've found it more difficult than if I didn't have a cage in to try to correct somebody once the cage was in. So if I would worry that I wouldn't be able to get a good enough correction. So I do think the cage prevents us a little bit from really getting that correction. And when you turn the patient prone, and again, this is what I'm surmising, is that I think we gain exactly the same amount when you're in the lateral, but you gain from the positioning before you put the cage in. So I don't have the exact numbers, but I do think that's what you get, because I don't think there's physiologically any different from putting a cage in when the person's prone than when the person's in the lateral position. It's just the positioning that gives you that, and then you can lock it in place. But don't tell anybody that, because someone will get mad at me. All right, good, thanks. So I guess we're doing yeah, this was my notes, so I could remind